Hi there, and welcome back to the Dutch Podcast. I'm Dr. Jaclyn Smeaton, and on this podcast, we dive into the vast and ever-evolving world of hormones as part of our lifelong pursuit of better health. Here at Dutch, we've dedicated over a decade to transforming lives by addressing hormonal imbalances like cycle irregularities, perimenopause, menopause, and more. Our mission is clear: to simplify and advance hormonal health for everyone. On this podcast, I get to bring you cutting-edge insights from our top experts on hormone therapy, menopause, personalized medicine, and more. We're all aimed at making a real difference in your well-being. Your questions and feedback are crucial. They shape our discussions and help us navigate the complexities of hormone health together. Now, as always, please remember the content of this podcast is for educational and informational purposes only, should not be considered medical advice. Be sure to consult your healthcare provider for medical advice, diagnosis, and treatment. On today's episode of the Dutch Podcast, we get to talk with Esther Blum all about the squishy details of perimenopause. Now, if you are in menopause, that 12 months cessation of menses, things start to get a little more clear. But for the 10 years before, they can be riddled with a wide variety of symptoms that go far beyond just hot flashes or vaginal dryness. So today we're going to talk about that, and really Esther does a great job breaking it down as to what's happening physiologically and why we experience this wide variety of symptoms. I think most importantly, you are going to walk out of this podcast with absolute clarity, no matter where you're at in the perimenopausal transition or even before, with what you should be doing right now to really set yourselves up for success through perimenopause and menopause. Now, Esther Blum is an integrative dietitian and a menopause expert. She's been working in menopause for almost 30 years, helping thousands of women go through menopause with nutrition, hormones, and self-advocacy. She really finds the proverbial light at the end of the vaginal tunnel. Esther is the best-selling author of See You Later, Ovulator, and several other books. Esther was voted Best Nutritionist by Manhattan Magazine, and she's known as Gwyneth Paltrow's menopause mentor. And she's been noted by Forbes by helping women thrive through menopause. She's been on the Today Show, and she's often quoted in publications including Goop, the New York Post, the LA Times, Cosmo, and more. Esther lives in Connecticut with her family, where she can be seen cooking up a storm. She does share some awesome recipes with us today, and going for long walks in nature, and lastly, singing 80s karaoke by the fire pit. We are going to have to save that for another time, Esther, but we're really excited to get started on the rest. So here we go. So Esther, we're so happy to have you today. We always have so much fun when we get to connect on the podcast.
We do. Thanks for having me back. Actually, I really appreciate it.
Absolutely. And today we get to talk about something that actually is the biggest reason that people order the Dutch test, which is perimenopause. That was a surprise to me, but when we surveyed customers, that came back as a top condition that they utilize a Dutch test for. Yeah. And it makes a lot of sense because it's kind of this confusing, murky, uncomfortable time.
Yeah, it's totally murky. I'm in it myself, and I appreciate everything that my own patients go through. And 60 to 70% of the people I do see are in perimenopause and do want the information. They do want to understand what's going on in their body. They go to their doctors, and a lot of women go from childbirth right into perimenopause without realizing it, because it can start mid-30s.
Wow, I never thought about that.
Yeah, it's really amazing, because women have choices to have children later in life, or maybe they don't meet their partner till later, and so they have children later, and then all of a sudden you can be nursing or pregnant and then stop nursing or stop being pregnant and have hot flashes, have vaginal dryness, have, a real dip in progesterone and depression and anxiety and night sweats and all these things, and really have no clue that you're in perimenopause. And so women are going to their doctors, and their symptoms are really getting missed. Their symptoms are being misdiagnosed. And so the Dutch is great, because it's why I use it, because I'm like, I don't really care what you think it is or isn't. Let's just open the hood and look underneath and see what exactly is happening during this time.
Awesome. So let's start with just defining the difference between menopause and perimenopause, because menopause is like a clear medical definition. Perimenopause is like the 10 years that lead up to it and all the symptoms, right? So let's talk about that. What is menopause officially?
Menopause is officially 12 consecutive months without a menstrual cycle. So let's say you go for 6 months, 8 months, 10 months without a period, and then you get one, you have to start the countdown clock all over again. Perimenopause is the 10, sometimes 15 years leading up to it, mostly 10, where we can still have the same symptoms, and the symptoms don't necessarily go away during menopause, by the way, without being treated for it. So we see everything, the garden variety of hot flashes, changes in mental status like brain fog, irritability, depression, anxiety. We can also want to divorce our spouses. That's not uncommon. Hot flashes, itchiness, vaginal dryness, nerve, what are called zaps, itchy ears, are some lesser knowns. Vertigo, lesser knowns, joint aches and pains, insomnia, weight gain, higher cortisol levels, higher, this isn't defined as like menopausal symptoms, but I do see also an increase in blood sugar and insulin, increase in cholesterol markers and plaquing on the arteries. So there's so many symptoms that I think it's between 60 and 80 different symptoms that can be classified as perimenopause.
I love that you're raising kind of the diversity of symptoms that women come in with, because traditionally we think about hot flashes and vaginal dryness.
Yeah.
And really that's kind of all, right? So it is commonly missed, because if you don't have those symptoms, or if you have a lot of others, they can sometimes be dismissed as not a problem or just part of aging, or how else do you hear these things redefined when you talk to your patients?
Yeah, well, and also I'll say, a doctor will say, well, you're not 51, so you can't be in menopause, as if our bodies are exactly on that clock. I have women in their late 20s to late 30s who've gone through full-blown menopause. And then I have ladies who are in their mid to late 50s just going through menopause. So there's no specific timeline. I wish it was a switch.
I feel like when I talk to women in perimenopause, a lot of them are surprised to be acknowledged for some of those, I wouldn't say like softer or like fringe symptoms, but things outside of the traditional hot flashes, libido change, vaginal dryness.
Yeah.
I think sometimes it's really affirming for women to hear like, no, this is actually a really common experience in perimenopause, to have the brain fog, to have mood changes, etc.
Yeah, it really is. And, the thing is, we're not educated on it at all. I mean, my doctor certainly never educated me. I was the one coming in saying, yes, my progesterone's really low. I'm starting to take it. I'm not sleeping so well. She just looked at me and said, okay, but never educated me and said, hey, you know what? You're approaching your 40s, you're approaching your 50s. Here's what you can expect for the next 5 years, 10 years. I even went to the GYN office. It was the night before Thanksgiving a couple years ago, and I had a left ovarian cyst that ruptured. So if any of you have had that, you can imagine the pain is like childbirth. Like I was crying. I was like, do I go to the ER? Oh my God, I'm in so much pain. So I go for my ultrasound, and they say, we have to test you for chlamydia. I was like, try again. What other options? I said, I don't think I have chlamydia. I work at home all day. And so is my husband. We're in a happy marriage. How about asking me that?
Right.
So then they were like, you're on hormones. Do you know you have an increased risk of breast cancer? I was like, okay, next. So they offered me the birth control pill, or told me to take Advil 10 days before or 10 days after. Now, fortunately for me, one of my dear friends is Amy Ropp, who's a fertility acupuncturist. She was like, don't worry, I've got vats of my special castor oil mix. Just rub that into the cyst every night. And the pain never came back after that. So I was like, the other option the doctor told me was that I could have a hysterectomy. So
wow, that seems pretty severe.
It was crazy. Well, the fact is I wrote that conversation when I wrote See It Later, Ovulator. I said, when you go to your doctor, this is the conversations you're going to have. So it shouldn't have surprised me that I had it with, the practice that I went to as well.
Well, it is interesting because when we look, we've talked with like several OB-GYNs on the podcast and just in, networking and all the conferences we go to, and they don't even get a single hour on menopause really in their residency or in their training. And I mean, I can pat ourselves on the back as naturopathic physicians. We did get 1 hour of menopause training, which makes you like a true expert, as you know, right? No, I'm kidding. There's so much to learn. There's so much data and research to understand and experience to be gained. But even a general provider or even an OB-GYN, unless they're doing it all the time and unless they're paying attention to the research, it's really easy to not know.
I'm shocked that you as a naturopath did not learn about it. I'm really shocked about.
We did. I mean, we did learn about it, but remember that you have 1 semester to learn everything in gynecology.
I see.
Right? So you have to cover everything for the reproductive years and peri and postmenopause. So even when it came to things like hormone replacement therapy, I mean, I went to med school when the WHI was published. So we, of course, learned the risks of hormone replacement therapy at that time. And the approach of, I'm saying that because things have changed for those of you that are listening. Things have changed, and that study was kind of flawed in its interpretation and its media exposure, especially. But we learned about what hormones to replace, some general protocols, but mostly we learned keep women on hormones for as short a time as possible at the lowest dose possible.
That's right.
And now things have really shifted in approach, which is, I mean, that's what happens with science, right? We learn more. And now there's so much more attention paid to women's health, particularly perimenopause and menopause, where we really didn't have much research before. So it's getting better.
And the good news is, I was talking to Kelly Casperson about this, and she said, because I said, well, when is it going to change in medical schools? Because we really have to start from the top down. I mean, I teach my clients, I'm like, change begins with us. Don't expect or wait for the system to change. You're going to be waiting 20 years. However, so I was talking about this with Kelly, and she was like, medical schools now, they no longer teach that hormones cause cancer. So that's a win. And about a week is given to menopause care, which I'll take it. I mean, I'll take something to just start normalizing some standards of care so that a woman, when she goes to her annual checkup, be it her primary care physician or her GYN, we've got 2 entry points to medical care as females. So they say, they look at your biological age and say, how are you feeling? Are you having any brain fog? Are you having changes in libido? Are you having hot flashes and vaginal dryness? Even if they don't go into the 20 other symptoms, at least if they open up the conversation around it, we're winning the game. But also absolutely. The thing is, when we go to the doctor's office, right, we really need to dedicate sessions specifically to ask for hormones. We can't expect the medical system now has 10 minutes allocated per visit, be it a pap smear or a checkup. So if you're interested in menocare, my advice is to get a separate appointment just for that, to ask about it, to ask about hormones if that's something you want to explore and take on. Don't do it while you're getting a pap smear, or don't do it, while your blood pressure is being taken. It's got to be a separate visit, and you've got to tell your doctor, I want to follow up with you on this. I want to get regular care, but I do need care on this. There are FDA approved hormones. I'd like to give those a try. So then you establish that you're partnering, you want to have guidance, you want to have support versus, it's the last minute of your consultation. You're still in your gown undressed and you're like, can I have some hormones now? And then you want to walk out the door because your providers are going to want to make sure that you're being followed up with too. It is a partnership. Doctors are not inherently evil. They go into this wanting to heal and help, but we have to partner with them as well.
I love that. And thank you for talking about that kind of soft skill approach. We always called those doorknob conversations. It's like after you've spent, for a naturopath, we'll spend 30 minutes or whatever in a visit. And as we're about to leave, you have your hand on the door and the patient's like, there's just one more thing. And it was really the thing that they wanted to talk about that whole time, but they were too embarrassed to ask or didn't know how to bring up, whatever. So
Yeah.
it's great to think about that. And it is really a partnership. And we talk about this all the time when we talk about hormone replacement therapy. Well, one, there's a wide variety of options for menopause care, not only
Yeah.
hormone replacement therapy. There's so many lifestyle things. There's herbs and nutrients that can be used. We can maybe talk about some of those. And then there's hormone replacement therapy. And when you get into HRT, we really do need to do an individualized assessment of every patient to determine whether they're a safe and best approach for a patient, and then which approach in that hormone realm is best suited for the patient, which route of administration, which dose, et cetera. So it's definitely not something that can be a quick prescription on the way out. I completely
Yes.
agree.
Yes.
So can we talk a little bit about perimenopause to menopause and what's happening physiologically? I mean, I kind of think about it as like a second puberty. Like the first time wasn't bad enough. We get to go through it at the other end of our reproductive years. And
yeah, we're backing out of puberty, basically.
Oh, gosh, it's brutal.
Oh, it's brutal. You know, for me, the progesterone decline really hit the hardest. So for a lot of women, right, we lose progesterone first because our body doesn't need our levels to be so robust. It's saying you don't really need to keep ovulating. We don't really want you to get pregnant after a certain point, after a certain biological age. So your progesterone production declines. You also need to understand the thing people forget to address is midlife. Okay. We've got aging, ailing, and or dying parents. And if we have children, a lot of them are teenagers. So, you know, and you're trying to launch them to college and get them to not crash their car, get speeding tickets all the time. And then if you've been a career woman, this is probably the time your career is really peaking because you've been doing this for 30 years or so. So, you know, we have all these stressors that can put us in fight or flight. And that is also going to tank our progesterone, right? Hormones start from the top down. So we have feedback mechanisms and feedback loops that tell your brain, will tell your ovaries, don't release an egg this month, don't ovulate, and does it by lowering your progesterone. So when that happens, we start to get crime scene periods, right? Massive blood clots, heavy. You're like, oh my God, this is the scene out of a John Gotti movie. Or of course, like I'll never forget the time I was wearing, very light tan pants. In New York City, I was like sofa shopping and I looked down and I was like, oh, we've got a situation here.
Oh no.
My bestie.
And you were clothes shopping.
Oh yeah. I was sitting on a butter yellow leather couch and I looked down. Thank God nothing got on the couch, but like my bestie gave me her sweater and we were riding the subway home with our husbands and they were just shaking their head. They're like, what is it with you girls? I was like, I had no idea. I don't know. So yeah. So when our progesterone levels tank, we can get really wicked cramping, very, very heavy bleeding, also insomnia, or that second half of the cycle. We are Jaclyn. The first half we're Hyde and we're like, all right, I'm pretty happy. I'm pretty chill. I'm feeling good. And then the second half sits and you're like, who are you? I hate you. And the devil takes over.
That's so relatable. I mean, honestly, I'm 44, so I'm like at very early stages, but I have seen change. And for me, the biggest thing is like, there's always a couple of days every month where I'm ready to like uproot my life, move, leave, whatever. And then I'm like, just don't make any decisions for 3 days. And every time I'm like, oh, hey, there we go. There's my cycle. I feel great again. It's that PMS that I'd never experienced before as well. It's wild.
It's wild. It's wild. I mean, I joke with my teenage son, he's 17 now. I'm like, the reason why you live in my house is because I take progesterone. Otherwise you'd be back in the shed in the woods. So yeah. So, really making sure that your progesterone is optimized is a fantastic way to transition from perimenopause to menopause. In the early parts of perimenopause, it's really, there's some great things you can do to support. I mean, maca and chaste tree can really support your adrenal function, can really eke out a robust production of progesterone from the ovaries. So you feel so much better. You could take it the second half of the month, but I really recommend just take it all month long to really support optimal progesterone levels. As you get later and later, and you'll know when those stop working and your symptoms are back, then we recommend women introduce progesterone the second half of their cycle when it all starts to hit the fan. And then really end stage perimenopause, where your periods are super irregular and not coming with any rhyme or reason, then you could take progesterone all month long.
Now, it is interesting. I think it's really helpful for women to kind of understand the common sequence. Now, perimenopause can be so diverse, but typically like the hot flashes and vaginal dryness are later in perimenopause from my experience with patients. The earlier signs are the kind of mood changes, cognitive changes, heavy bleeds, and those are more progesterone. Like progesterone will, the decline of progesterone is the first thing that women experience. And that happens physiologically because that's kind of a slow, gradual decline into menopause versus estrogen. Let's talk about estrogen.
Oh,
it's a bit of a roller coaster.
Estrogen levels can fluctuate up to 30% on any given day. And this is why most practitioners do not want to test prior, because they're like, it's going to be crazy from 1 month to the next. And we really don't want to test. It could be crazy from one day to the next. And this is harder to control and regulate. But again, this is why you're preaching to the choir. I'm a fan of the Dutch because I like to look at how estrogen is moving through your liver and also your gut. And if it's not moving through well, if it's getting backed up, if the sink isn't draining, then you can have more of an impact emotionally. You can feel, more weepy, more irritable, more breast tenderness, more bloating, a lot of fluid fluctuations and water retention, versus supporting your detox pathways, maybe, whether it's phase 1 or phase 2, it depends on which pathways you need supported. For some women, it's glutathione and taurine. For other women, it's and choline, trimethylglycine. Other women need cruciferous concentrates and really eating a good amount of cruciferous vegetables and fiber, flaxseed and chia as well. So that is really individualized. But the progesterone, again, you'll know in later perimenopause when it's really time to bring it in is when you are having hot flashes, when you're taking progesterone and still not sleeping well. Progesterone will help you fall asleep, but estrogen helps you stay asleep. It's really getting the ratio right. Also, if you're having migraines, I have seen very successful treatment of migraines when the ratio of estrogen to progesterone is right for your body. I don't have an exact number of what that is. It's trial and error and it is individualized, but that also helps too. And so when you quell your hot flashes, when you're using vaginal estrogen as well, and that's helping, that's how you know that you did the right thing by bringing it in. And I do look at the Dutch, but I also look at blood work concurrently to really verify and optimize recommendations. I can't prescribe, but I can say, here's what you can ask your doctor about. And then they work with, I always refer out. It's outside my scope to provide, but I can certainly suggest and recommend.
I love that you kind of bring up the variation too in estrogen. I think that's one of the challenging things because it is truly difficult to test when you're in perimenopause.
Yeah.
Postmenopausally, hormones become a lot more stable.
Yeah.
But in perimenopause, you're right. I mean, you have this variation within the day, which the Dutch can overcome, that 30% variation from hour to hour, like you talk about.
Yeah.
But there is also the day-to-day variation that can be pretty significant, which is another thing that I think is great to bring up because sometimes women will get on estrogen therapy and they'll feel really great if they're in perimenopause, but then they'll feel terrible because they start to have signs of estrogen excess. And that can be because all of a sudden their ovaries are secreting estrogen and that extra amount is too much for a period of time. So it can be very difficult to treat in perimenopause versus in menopause when things are stable. It's much more easy to find a comfortable dose. So if you're a patient, it's not your provider doing something wrong. It's that your body is probably still in flux through that
That's
time. I don't know
right.
if you've experienced that, but one great analogy I heard, which I love to share, is that the ovaries in perimenopause are a bit like a ketchup bottle when you're on like the very last serving. Isn't that so funny? It's like you shake it and nothing comes out and nothing comes out. And then all of a sudden, like, yeah, it's like ketchup everywhere all over your hot dog. And that's a lot about what the ovaries do. And it's because they're getting signals from the brain. And sometimes things don't click and then sometimes they do. Or you
Yeah.
might get a cycle where you ovulate or, you get a follicle, a dominant follicle that gets made and surges estrogen. So it
Yeah.
can be so unpredictable. And so just keep that in mind if you're feeling frustrated because you're like, I felt great for a couple months and now I
Yes.
don't.
And this, I can tell you this has happened to me. I work with my doctor on it. I started off at higher doses. Then I had to drop down to lower doses because my estrogen was too high. I mean, I had my Goldilocks moments. We dropped down. Then I started feeling really crummy, like the dead lady in the bathtub in The Shining kind of crummy. And then we bumped it up. And just this month, I was like, oh my God, like I finally have had a month of just not feeling dead. And it's like the period flu, but 24/7 all the time.
Mm.
So it is trial and error. And you have to be patient and expect that the wheels are going to come off the bus. It's not linear. Your body does what it wants when it wants to. I can tell my ovaries to, piss off, but they're still going to do what they want to do when they want to do it. So yeah, and my cycles could be 40 days, 60 days, 20 days. There's still no rhyme or reason, but it does get better. And adding in testosterone, adding in vaginal estrogen if needed, all those things also make a huge impact on energy, cognition, mood, focus. So libido, all of those things are wonderful too.
So can we talk a little bit about some of the influencing factors? Like why is it that some women have a harder time with perimenopause and menopause and others experience very few symptoms, or they have this prolonged perimenopausal period versus a short perimenopausal period? Do we have any understanding of what influences that?
Well, first of all, we're seeing perimenopause earlier and earlier. And if you look at the volume of endocrine disruptors in our environment and our stress, that can absolutely lead to a more premature ovarian failure, just because if you're in a chronic flight or fight state, and that can absolutely impact if your fight or flight state is from current versus past events. For instance, there is hardcore evidence that women of color, lower socioeconomic status, women who've experienced trauma with a capital T, all of that can also lead to earlier perimenopause and more difficult perimenopause. We know that during perimenopause, as the ovarian party winds down, the adrenals really have to pick up the slack, start to step in for hormone support. And so the worse our cortisol levels are, the more rock bottom they are from chronic stress and burnout, that will, certainly make your symptoms feel worse. It will make you feel more fatigued, more draggy, make your symptoms worse, could make your hot flashes work as well. And so
let's stop and double click on that because I think that's like such a cool point to bring up. I love how you call it the ovarian party. As the ovarian party is winding down, I'm going to take that phrase. Thank you very much. But so typically in a cycling female, the ovaries are producing estrogen. The granulosa cells are producing estrogen as follicles mature. And then that gets transmuted into the corpus luteum, which makes progesterone in the second half of the cycle. But what you're saying is that as that slows down, the adrenals have to take over. And that's like real science. It's basically that the only estrogen you make is it starts with DHEA production in the adrenal glands. That's what you're getting at here, right?
Yes. Thank you. Yes.
Yeah. So the adrenal glands make DHEA and then that gets converted to a variety of hormones, but eventually to testosterone and then to estradiol from testosterone. So it's it's really, really important because it's the only source. It's like the only well. I'm trying to think of a good analogy, but like, you have to kind of dip into your secondary well because the first well is run dry to really have the influence that you need. So yeah, if the adrenal glands aren't, if they've been taxed through chronic stress for a long period of time, there might be disruption in the communication along that pathway.
That's right. That's a huge, huge, huge impact. And also, we have to look at gut function. Having a significant drop and decline in estrogen and progesterone is going to disrupt the gut microbiome. It decreases our production of hydrochloric acid. It can change the epithelial lining of the small intestine. There can be a lot more inflammation there. So oftentimes, this is why I do stool testing alongside the Dutch. And I've had women whose hot flashes have resolved just by healing inflammation in the gut. And the brain fog disappears, healing inflammation in the gut. We know if we have a leaky gut, we have a leaky brain. So all of those pieces are really important to address. It's not only coming from a change in hormones or adrenal function, it's also coming from a change or disruption in gut function. So the better your gut function in menopause, the better your symptoms and your journey will, or through perimenopause, the better your journey will be as well.
Okay, so we've talked about stress and adrenal function. We've talked about gut health. You've also brought up environmental toxicity and the role that probably has on the timing. Anything else that jumps to mind for you? What about nutrition or exercise?
Yeah, I was going to say, diet and diet, I already said stress management, and exercise, will it change the outcome in the onset? No, but can it manage the severity of the symptoms? Absolutely. So first of all, let's start with the exercise piece, which is really my therapy, is walking outside twice a day. Getting that morning light is a spectrum that's 200 times greater than any indoor light bulb, especially with all the LED bulbs that we're now, exposed to on a daily basis, even in our own homes. So getting outside in nature lowers cortisol, regulates your circadian rhythm. For me, it's my greatest antidepressant. It's such a mood elevator. It's so calming. It's restoring. And also, it helps burn fat. I mean, when you're walking 6-8 miles a day, you're not going to develop that menopause so easily. Your body will stay much more regulated and not gain all that weight at once. Certainly strength training too. The more muscle mass we have, the leaner we are, the better we manage our insulin, the better we support our bone density and manage longevity, right? We didn't talk about losing bone mass. Peri is a huge sign of perimenopause. It happens in perimenopause. Most people don't realize we lose the largest amount of bone in the last couple of years of perimenopause. So by the time we get into menopause, and then your doctor says, "Oh, you should have a bone scan at age 63." No, you're already far gone by then. So early intervention of estrogen is really key for optimizing bone health and bone density as well. And strength training really supports that and counteracts bone loss. And then we have diet. So diet is really going to optimize your microbiome, especially fiber. Fiber, again, keeps estrogen in check, binds excess estrogens, acts like a sponge to really mop them up and shuttle them out via your bowel movements. But also, fiber regulates your blood sugar. It's food for your microbiome. It's food for your good bacteria to eat. So colors, dark green leafies, reds and blues, all of those foods really support healthy gut microbiome, but also diversity. Like we eat the same, chicken on Monday, fish on Tuesday, meat on Wednesday, but so your proteins may not vary as much. However, your produce and your starches can vary a tremendous amount. You have sweet potatoes, white potatoes, and which white potatoes cooked and cooled are very high in resistant starch, which is great for the gut. winter squash, legumes and beans, if you tolerate those, dark green leafy vegetables, rice and quinoa, if you tolerate those. And then, vegetables, I'm like, just buy one different vegetable a week than you would normally eat. Buy eggplant one week and roast it with some red peppers, put it in tomato sauce, over meat. Or red apples are in season as we record this, and there's so many different varieties of red apples. So buy different varieties of red apples. You don't have to eat berries year round just because they're available. Like, give your body a break from eating the same foods all the time.
This is great. We're going to have you on for like a cooking show because you have a lot of really good ideas. So it's going to be like the next book will be a recipe book, and our next podcast will have a kitchen.
Yeah, let's do it.
That'd be so fun. Yeah. And I love that thought of food as medicine and like getting the diversity, anything that adds color or flavor or aroma to a food is usually a phenol containing compound or a flavonoid. It's a nutrient. It's a plant nutrient. So I call them plantioxidants instead of antioxidants. And a lot of them don't have names, right? But you want the diversity of that in your diet. And you're right. You get the diversity of micronutrients, but you also get the diversity of fibers. And that's so critical for gut health. I love that you bring that up. So I think my last question for you is, as women start to see these symptoms come up for them, what should they start by doing on their own? And you've talked about this, like balanced blood sugar, exercise, things like that. And how do they know when they need to go ask someone for help?
Yeah. Well, there isn't a woman out there who doesn't know her own body. When every woman who says, I think it's my hormones, you're always right. Because when your monthly cycles either start to shorten or lengthen or just get wonky in terms of flow volume, or again, your moods are so shifted and you just don't recognize yourself, or the weight gain starts, that's the minute you feel off, schedule an appointment. Don't wait, because it doesn't get better without treatment. It doesn't go away. There are women I treat in their 70s, and the minute they stop doing all the things, their hot flashes come right back. And their vaginal dryness and their skin gets more wrinkled up without all that beautiful estrogen. So, go right away. Don't wait. I did write, I've a whole book called See You Later, Ovulator, where I walk you through the tests you have done. I tell you all the blood tests to have done. Look at your inflammatory markers. Look at your insulin levels. Look at your thyroid function. Look at your cardiac risk markers. Start to see, I've never had, really high LDL before. I've really never had high homocysteine, and now I do. What's going on?
And that's a super common change that women, we don't talk about a lot, like in the medical space, but a lot of women get put on cholesterol lowering medications around this time, but it's very much, it can happen so fast with no dietary change, really just with the hormonal change. So I'm glad you bring that up.
Yes. And also remember too, that birth control pills and antidepressants are not menopause care. They're Band-Aids, right? Or putting in an IUD or having an ablation for heavy flow. The start is with progesterone. That's what's deficient. That's causing a lot of your symptoms, psychological, physiological as well. So, adding in progesterone or, as we talked about, Chase Tree or Maca, either way, you may need to go outside your regular doctor's office. You may need to work with a functional medicine practitioner. I do love the Dutch and I love the GI map to help understand and get a really clear window into what's happening. But if you don't want to do all those tests, or if they're outside budget, then still work with a hormone literate doctor who's going to say, all right, listen, for some doctors, they may just test your blood. Some doctors may just test your symptoms. You should always make sure you're going to get retested, but every state has at least one local compounding pharmacy in every state. So call your local compounding pharmacy and say, can you please hook me up? Who are either your naturopathic physicians, nurse practitioners, or hormone literate MDs or GYNs who can prescribe hormones or who can guide me through perimenopause, right? And so knowledge is power, and working with someone really good from the get-go is the greatest investment that you can make in yourself, because you will have your quality of life. You will be able to do your job. You will save money from hiring a divorce lawyer. You will improve your relationship with your family and your kids and your friends. And you will not want to mass murder everybody. You'll be happier mood, sleeping, happy romantic sex without dryness, without pain. You'll have a libido. You don't have to gain a ton of weight or any weight in perimenopause and menopause. So it can actually be an amazing time in your life. But early intervention is really the biggest, most important step you can take.
I love that. I remember in medical school, someone teaching that health it's not only the absence of disease, it's like the ability to live with freedom and do what you want and be your best self. And that's what's resonating for me as you speak, is like, you can have that through this time that sometimes feels difficult for women. And I love that that's really the goal that you're talking about, is that optimal, beautiful life where you get to really be that full expression of yourself without limitation.
Yes. And also, again, when you have a team in place that's going to support you, you're going to free up mental real estate. I mean, how many of us have been up at 2 a.m. Googling, like, how do I get rid of my hot flashes? How do I sleep through the night? What's happening to my body right now? I'm 54, right? Versus investing some time and financial resources into just a session or two with a practitioner who's going to meet with you regularly. Once you're out of the moving parts of perimenopause, like you said, like once your hormones are low in menopause, you're stable. It's like, that's when I get the best results with women losing weight, and women who have never been able to lose weight or haven't lost weight in 10 years with very stubborn body fat and just absolutely no energy and brain fog. They're like, oh my God, you brought me back from the dead. Like, is this still possible? Yes, it's totally possible. So, but again, I don't want women waiting 10 years waiting. I want them to address it in real time as it's happening. And you could say, okay, you know what you're doing. I'm going to work with you. I'm going to tell you what my symptoms are. I'm going to check in until my hormones are stable. And then, we'll retest as we go. And then you just move on with your day. You don't even have to think about it. You just are like, all right, I feel good today. Even on crap night's sleep, I feel good today because got my hormones. I'm eating my protein. I'm getting my workouts in. And, it can really be amazing.
That is amazing. Well, thank you so much. It's always so awesome to have you on the podcast. And you mentioned it a couple of times, but Esther's newest book, See You Later, Ovulator, which is absolutely the best title I've ever heard. You can check that out if you want to learn more about her approach to perimenopause and menopause care. And where's people's best place to find you on the web?
Yes, please find me on Instagram at Gorgeous Esther and at estherblum.com, EstherBlum. We have so many resources there for you. And depending on when this comes out, I'm doing a World Menopause Day event as well that will be recorded and accessible through the site. So we're going to have just so much to support you with and get you through.
Fabulous. All right. Well, thank you so much. Have a great
Thanks,
day.
Jackie.
If you're wanting to learn and really expand your expertise in hormones, you're not going to want to miss our podcast. So make sure you tune in each and every week for our new content.